Welcome to the Explainer. Today, we're taking a structured journey right through the bloodstream to decode complex vascular pathology. We are going to explore the very pipelines that literally keep us alive, and we'll look at exactly what happens when things go wrong on the circulatory highway. We'll be scaling all the way from simple inflammation to rogue aggressive tumor construction. It's a truly fascinating ride, so let's just jump right in.
Here's our roadmap for today. Number 1, anatomy of a vessel. 2, large vessel vasculitis. 3, medium vessel vasculitis. 4, small vessel vasculitis. And finally, number 5, tumors of the blood vessels.
Starting off with Section 1, Anatomy of a Vessel, the foundation. Now, to truly understand how things go wrong, we first have to establish our healthy anatomical baseline. These normal vessels are built with 3 distinct layers. You've got an inner layer called the tunica intima, which is lined by endothelial cells. Then a muscular middle layer called the tunica media. And wrapping it all up is an outer layer known as the tunica adventitia. Right between these layers, there are these wavy elastic borders separating them, the internal and external elastic lamina. But here's the catch. To actually see these crucial elastic fibers under a microscope, pathologists have to use a highly specific stain called the Verhoeven-Van Giesen stain. Okay, so now that we know what a healthy structure looks like, let's introduce our core pathology for the day, vasculitis. Simply put, this is an inflammation of the blood vessels. And remarkably, the exact cause is often idiopathic, meaning we don't always know what triggers it. But we do know that it's heavily associated with ANCA, or anti-neutrophilic cytoplasmatic antibodies. Basically, these are rogue antibodies circulating in the blood that decide to attack our own neutrophils. They come in 2 main flavors: P-ANCA, which deposit tightly around the nucleus, and C-ANCA, which are scattered throughout the entire cytoplasm. These rogue antibodies are the invisible drivers behind many of the dangerous diseases we're about to dive into. To keep all this straight, it helps to break everything down into 3 main buckets. Think of them as large highways, medium city streets, and small neighborhood roads. You see, the exact size of the inflamed vessel entirely dictates the specific disease, and ultimately the symptoms a patient is going to experience.
Moving right along to Section 2, large vessel vasculitis, the highways.
Let's see how granulomatous inflammation can create massive, dangerous roadblocks on our major highways. Applying the rule of contrast is honestly the best way to understand these 2 major large vessel diseases. On one side, we have temporal arteritis, which is also known as giant cell arteritis. This one typically hits older females, usually over 50. It attacks the superficial temporal artery and the facial artery, which causes severe unilateral headaches and pain when chewing, a symptom known as jaw claudication. On the flip side, we have Takayasu arteritis. This strikes a totally different demographic, younger females, usually under 40. It targets the massive aortic arch and the subclavian arteries, and it obliterates the blood flow to the arms so severely that it's actually clinically known as pulseless disease.
So, getting back to temporal arteritis, the absolutely crucial point for diagnosing it is taking a massive 3 to 5 centimeter biopsy. You might be wondering, why so large? Well, because the granulomato's inflammation here is segmental. It skips around. If you take too small of a piece, you might just sample a healthy gap and completely miss the diagnosis. And if you even suspect this disease, you have to start immediate steroids alongside aspirin. The inflammation can rapidly spread to the ophthalmic artery, and without rapid treatment, the patient is going to suffer irreversible vision loss. It's a real race against the clock.
All right, on to Section 3, medium vessel vasculitis, the city streets. Narrowing our focus down to the medium-sized vessels, our first major culprit is polyarteritis nodosa, or PAN. To remember this one, just use the Plan B mnemonic. The B is key here because it reminds us that about 30% of these cases are closely linked to hepatitis B surface antigen positivity. PAN causes a severe transmural fibrinoid necrosis, meaning the entire vessel wall dies and forms this bumpy string of beads nodular appearance. Interestingly, though, it strictly spares the pulmonary arteries in the lungs, but it heavily targets the renal arteries. This leaves the kidneys peppered with small hemorrhages, giving them a very intense, flea-bitten appearance. Next up is Kawasaki disease, which is a pediatric vasculitis that primarily hits children under 4. To memorize this, picture a little boy crashing a Kawasaki motorcycle while holding a corona. Why? Because Kawasaki disease heavily targets the corona, or coronary arteries. This can tragically lead to a fatal myocardial infarction in a very young child. The disease is driven by anti-endothelial antibodies and presents with the CRASH symptoms. That stands for conjunctivitis, a polymorphous rash, adenopathy, which means swollen lymph nodes, a distinct strawberry tongue caused by mucositis, and finally, peeling hand and foot edema.
Rounding out the medium vessels is Berger's disease, formerly known as thromboangiitis obliterans. This one aggressively targets young, heavy male smokers. It uniquely inflames the entire neurovascular bundle. We're talking the arteries, the veins, and the nerves. They are all affected, while it oddly completely spares the lymphatics. It causes intermittent claudication, which is severe pain when walking, along with obliterating thrombi that block blood flow so completely that it can lead to dry gangrene. Ultimately, this can result in the pretty horrifying outcome of auto-amputation of the fingers.
Down to the micro level now. Section 4, small vessel vasculitis, the neighborhood roads. Take a look at the contrast here between two closely related small vessel destroyers. First, we have Wegener's granulomatosis. Just remember the mnemonic Wegener's with a C because it is C-ANCA positive and it features granulomas. This completely differs from microscopic polyangiitis or microscopic pan. Now, both of them share a deadly combination of coughing up blood and urinating blood, hemoptysis and hematuria, but microscopic pan runs on P-ANCA and it completely lacks granulomas.
Let's look a little closer at Wegener's. It presents with a highly destructive clinical triad: the nose, causing a collapsed saddle nose and strawberry gums, the lungs, causing hemoptysis, and the kidneys, causing rapidly progressive glomerulonephritis and hematuria. To treat this severe triad, we rely on the drug cyclophosphamide. But you gotta be really careful here, because its toxic byproduct, a chemical called acrolein, can severely irritate the bladder, leading to a tremendously painful complication called hemorrhagic cystitis.
To finish up our tour of the small vessels, we have two very specific conditions. First is childhood henoch-Schulin purpura, or HSP. This is actually the most common childhood vasculitis, and it's driven by IgA antibodies depositing right into the vessels. It causes a very classic palpable purpura on the buttocks, joint pain, and an intensely painful telescoping of the intestines called intussusception. Then there's the allergic Churg-Strauss syndrome. This one features severe allergic asthma, high levels of eosinophils in the blood, and tragically, those eosinophils often infiltrate the heart muscle, making congestive heart failure the most common cause of death. So that completely covers the vascular inflammation side of things. But looking at all this blockages naturally leads us to ask a rather dark question. What happens when the vessels don't just inflame and get blocked, but instead begin to uncontrollably multiply and build their own chaotic structures? Which perfectly tees up Section 5, tumors of the blood vessels. Pivoting from temporary roadblocks to rogue construction, let's start with the benign, non-cancerous tumors. We can compare two main types of hemangiomas here. Capillary hemangiomas, which are often called strawberry hemangiomas, usually appear on the skin of infants. They might look a bit concerning, but they naturally and completely regress on their own by age 7. On the other hand, cavernous hemangiomas feature highly branched, massive blood vessels. They tend to involve deep organs like the liver and the central nervous system. Unlike the capillary ones, they absolutely never regress, and they're highly associated with a genetic condition called von Hippel-Lindau syndrome. Another fascinating benign tumor is the glomgioma. If you ever spot a severely painful, small tumor directly under a fingernail, it's very likely to be this. It arises from the glomus body, which is an arteriovenous anastomosis that essentially functions as thermoregulation for our fingers. If you were to look at this tumor under a microscope, you wouldn't just see blood vessels. The structural septa, right between the vessels, will be densely packed with very distinct round monomorphous cells.
Finally, escalating the stakes dramatically, we move into actual malignancy. In the intermediate risk category, we have Kaposi sarcoma. This presents as distinct lesions on the lower limbs of immunocompromised patients, such as those with HIV. But it's actually driven by a viral infection, specifically the human herpes virus 8, which goes in and creates these wavy, spindle-shaped neoplastic cells. Leading us finally to the most aggressive tier, angiosarcoma. This is a brutal, highly malignant cancer of the endothelial cells themselves, testing positive for the CD31 marker. It's wildly aggressive and notoriously driven by toxic chemical exposures, specifically things like arsenic poisoning, polyvinyl chloride, or an old retired radiocontrast agent called thorotrast. We've seen how perfectly normal anatomy can succumb to targeted inflammation and how benign growths can sharply contrast with aggressive toxic malignancies. So to conclude this explainer, I want to leave you with this final thought.
If our circulatory highway is so intricately fragile, what other hidden pathologies might be silently driving through our most essential network right now? Thanks for joining me on this explainer. Keep asking questions, and I'll catch you next time.